start off by saying I apologize for my voice and maybe a little hoarse. I'm going to try to get through this without losing it any further. It's a pleasure to talk to you this morning about something that's of interest to me, which is the clinical utility of genetic analysis. I'm a clinician scientist. I have a busy clinical practice at Stein, where I'm the chief of cornea service, and also I have a research lab funded by the NIH that focuses on the molecular genetics of inherited corneal disorders. And by way of disclosure, I am a consultant, and as I'm doing this morning, do speak for Avellino Laboratories. Well, as part of a task force commissioned by the Academy of Ophthalmology a number of years ago, that was chaired by Stein, to look at the usefulness of doing genetic testing in clinical practice. And one of the major points from this was that we don't think that testing for complex disorders, such as macular degeneration, routine clinical testing, really has a role today in managing our patients. But we did, however, state that we felt that there was a role for clinical testing for patients with Mendelian disorders, of which the corneal dystrophies, almost all of them are, in helping us to guide clinical care in certain situations. I'll highlight some cases in which I found that genetic testing was useful clinically. My colleagues, many of them are corneal specialists, and they say, well, I don't need genetic testing. Well, some refractive surgeons, I don't need genetic testing to identify these conditions. I can rely on what I see in the lab, I can rely on family history to accurately diagnose these patients. And I would put it to you that neither of those are really reliable means of diagnosing corneal dystrophy. Referential analysis is certainly the most definitive means of differentiating between inherited and non-inherited disorders of the cornea. So I'll talk first with a couple of cases regarding screening of refractive surgery candidates, the usefulness of genetic testing in that arena, and then differentiating between dystrophic and non-dystrophic corneal opacities. So we'll start with the case of a 43-year-old woman who presented to a LASIK surgeon interested in refractive surgery. She wore glasses, contact lenses for correction of moderate myopia and astigmatism. Family history of this patient is unknown. These are not her images, but these images show what was reported to be seen preoperatively prior to the LASIK surgery. The patient had a few fine stromal deposits, as you can see, located in the central cornea of the right eye, and here in the left eye had a single solitary deposit. So in this case, the patient's corrected vision was May 2020. The surgeon felt that the patient was a candidate for refractive surgery, and so the LASIK was performed. A year later, the patient underwent an enhancement in each eye. The patient did well for a period of time, but then presented to the surgeon 4 years later, complaining of decreased vision in each eye. So here you can see, obviously, significant exacerbation of these stromal deposits. This is in her left eye, see on direct and retroillumination, and here in the right eye, again, see this is a significant worsening. And you'll note in the thin slit figure that the deposits are in a linear pattern here, just below the surface of the cornea. In fact, that does correspond to the LASIK flap interface. So here on the resolution OCT of the right eye and of the left eye. And so there's no question this is caused by LASIK surgery because we see that hyperreflective band at the level of LASIK flap interface. That's not the only patient I've seen. This is a patient from San Francisco who I just got clarification from this person who saw this patient and referred the patient to me. So the patient had a few fine stromal deposits, similar to the first case, prior to surgery. This is about 2 years, I believe, after surgery. The right eye, again, you can see the deposits in the LASIK flap interface. And in the left eye, needless to say, at this point, this patient is not going to have good quality of vision, and it will usually require some sort of additional surgical intervention. This is a patient from Colorado who I saw, who had LASIK surgery. This was probably around 2000, roughly, when the first report came out in literature of exacerbation of Avellino dystrophy, or combined corneal dystrophy, retinal corneal dystrophy type 2. Around the time it came out in literature, this case, the developed this patient had LASIK surgery, so the surgeon was unaware of this association. You see a significant exacerbation of the deposits in each cornea, and this patient went on to bilateral corneal transplantation. Now, at this time, this association, like I said, was just being reported. So the surgeon can be faulted here. But certainly if this patient presented to the surgeon again at this time with this known association, I think all of us would agree it would be below the standard of care to proceed with LASIK surgery for this patient. The histopathology from that case I just showed you, again, demonstrates the linear deposits of the TGF-beta protein here in the anterior corneal stroma corresponding to the LASIK flat interface. None of these patients had genetic testing performed prior to surgery. And they had performed what would have been noted, thank you very much, was the presence of this mutation here. So a nucleotide change causing a change in the encoded amino acid from arginine to histidine codon 124. That's the classic mutation associated with granular corneal dystrophy type 2 or Avellino corneal dystrophy. For comparison, there's a control DNA sequence. This is what the sequence should look like in this patient. So again, if you have a patient who has a few of these stromal deposits, not sure what it is, there's usually a family history, but not always. We and many other groups have reported individuals without a family history who have these inherited corneal conditions. So what are the indications for screening? Well, these are a few. Presence of unexplained corneal stromal opacities in individuals under the age of 40 with Korean or Japanese ancestry. This condition, granular corneal dystrophy type 2, is the most common corneal dystrophy in Korea. It's the number one dystrophy that they see, more common than Fuchs, more common than full-base amyloid dystrophy. Family history of a TGF-beta dystrophy. I think everybody who performs refractive surgery should have a questionnaire. Most of you do. But you ask various questions, and one of them should be family history of inherited corneal disease, anybody with family of corneal transplant, etc. This information that should not be missed. Family history of corneal transplantation for an unclear reason. You're not sure why somebody with family of corneal transplant, you need to try to figure out why. Because that's what it's a for TGF-beta dystrophy. These conditions can have an early onset in the teens, but sometimes even in the 20s, this condition, granular corneal dystrophy type 2, can be very subtle and it may be missed. We're talking today about Avellino test. I have actually used this in my practice. The patient is going to look like combined granular dystrophy, look like granular dystrophy type 2, Avellino corneal dystrophy. And in this case, I performed testing, sent the sample. Avellino came back within just days. You see it's very easy to read printout, which shows that the patient would be heterozygous. They carry the mutation. This patient, in this case, would not, so a great candidate for refractive surgery. The second case is a 49-year-old woman who presented for refractive surgery evaluation. She's an RGP wearer. She has an unremarkable family history, so no family history of inherited corneal disorders. You see, she's a moderate to high myope, it's -5 and quarter to 5.5, well amount of astigmatism. Corneal pigmentary normal. In the left eye, she had an endothelial opacity in the cornea that looked like a band associated with posterior polymorphous corneal dystrophy. Preoperative tomography is fairly unremarkable. You see there's about a quarter dot of astigmatism in the right eye. In the left eye, there's about 1 1/4 dot of astigmatism. There's nothing that's suspicious.
There's nothing that's suspicious about these topographies. Okay, thank you. So in this case, you have a patient who has a fairly unremarkable refraction, unremarkable corneal thickness, unremarkable topography, in whom there'd be really no reason not to do counterrefractive surgery. The only finding, again, was that she has posterior polymorphous corneal dystrophy. So in this case, she had LASIK surgery performed, and this patient developed bilateral corneal ectasia requiring cross-linking. So the question is, why did this patient develop bilateral corneal ectasia without any identified risk factors preoperatively? Well, this should not surprise anybody here. We reported posterior polymorphous corneal dystrophy is a corneal ectatic disorder following association of this condition with significant corneal steepening. Dr. Marshall showed some nice images of the TGF-beta expression in the cornea, and posterior polymorphous corneal dystrophy is associated with mutations in this ZEB1 gene that's expressed not just in the corneal endothelium, but also in the corneal stroma by the keratocytes as well. And we have shown that if you have a mutation in this gene, about 86% of patients will have not just posterior polymorphous corneal dystrophy changes in the endothelium, but also very steep corneas. On average, 53.3 diopters. We'd say, okay, I certainly wouldn't do refractive surgery if somebody came in with a steep cornea. But the thing is, we don't know whether when the corneal steepening develops. It's possible that these patients may have the endothelial changes of posterior polymorphous corneal dystrophy prior to the onset of the corneal steepening. So again, if you do LASIK on these cases, you can exacerbate the corneal steepening as it occurred in this patient's case. So this is another instance in which we would advocate genetic testing. In this case, if a ZEB1 mutation is found, knowing that 86% of individuals with ZEB1 mutations either have or will have corneal ectasia, this would be a relative, if not absolute, contraindication to LASIK surgery. So what are the indications for screening ZEB1 gene prior to ketorefractive surgery? Well, the presence of unexplained corneal endothelial opacities, a family history of posterior polymorphous corneal dystrophy, corneal ectasia, or corneal transplantation for an ectasia or non-Fuchs endothelial dystrophy. In this case, the samples can be sent either to a research laboratory, such as the one that I direct at the Jules Stein Institute, or a diagnostics laboratory such as ASCRS, which is located in Estonia. And there are others. And maybe someday, hopefully, Avellino laboratories will offer testing, not just for granular corneal dystrophy types 1 and 2, but we'll expand it to testing for other corneal dystrophies, which their clinical testing would be clinically relevant. So let's talk now about differentiating between dystrophic and non-dystrophic corneal opacities. This is a case of a 65-year-old gentleman who presented to me with slowly progressive decrease in vision over the previous several years. There was no history of ocular trauma, no history of recurrent corneal erosions, no family history of poor vision or corneal transplantation. In the right eye, you can see that there were a few branching stromal opacities. You'll note also in the reflex off the IOL that there was sort of diffuse ground glass appearance to the corneal stroma. I don't know if we can do anything to dim these lights anymore, but if we could, you can see that there's some branching opacities here in the stroma, in that right eye, that are also seen here in the left eye. So in this case, the diagnosis was presumed lattice corneal dystrophy. That's what it looks like. Well, we did screening of the TGF-beta gene. As I mentioned, if you have granular corneal dystrophy type 2, you would have a mutation at this position. Lattice is also associated with a mutation at the same codon, same position. In this case, he did not have one. Well, there are lots of different types of lattice dystrophy. We and other groups have reported many different mutations in this same gene associated with some strange variants of lattice, where the lines show up later in life, deeper in the cornea than usual, etc. So we screened the entire gene, did not find any mutations. So the story does not end there, though. If you have a patient who has what looks like lattice dystrophy, in which you don't find a mutation in this gene, there is not a family history, then you need to be worried about secondary amyloid deposition associated with systemic malignancy. So we referred this patient on to an oncologist, and he was diagnosed with monoclonal gammopathy of undetermined significance. And this is one of about maybe a half dozen patients I've seen with this entity. Here's another patient who presented what looks like lattice lines in the corneal stroma. Screening the gene did not identify a mutation. This patient has now been diagnosed with myeloma. You cannot miss this patient in your practice. And these patients, most of these patients were seen initially by a comprehensive ophthalmologist who then referred the patient on to me. Another patient who looks like lattice, in which case genetic testing demonstrated no mutation in the gene. This patient's systemic workup is negative, but it will be repeated in the future because I'm concerned that she ultimately will also develop a myeloproliferative process. The fourth case is an 8-year-old boy who I saw. This case is very new. I just saw this child a couple of weeks ago. Came from Atlanta, referred to me with a history of severe photophobia since he was 1 year old. He's a healthy little boy otherwise. He had an EUA at age 2, diagnosed with Meesmann corneal dystrophy. Basically, there's no family history of Meesmann corneal dystrophy. He's 8 years old, so he's a little hard to photograph, but I can tell you this is his right eye. You can see there are a number of clear epithelial microcysts that are diffusely distributed, which is, at least in my book, fairly characteristic of Meesmann corneal dystrophy, with some unusual, at least for Meesmann's, unusual parallel lines in the epithelium. So a little bit of an unusual appearance for Meesmann dystrophy. In the left eye, we see similar changes. These cysts appear to be gray-white on direct illumination and clear on retroillumination, as you can see here along the edge of the pupillary border. And there again, those linear changes in the epithelium in the inferior aspect of the left cornea. And those changes stained with fluorescein. So took a look at mom who accompanied the patient. This is her right eye. This is the left eye. Both corneas were clear. So I said, let's take a look at dad. Here's the dad's right eye and the left eye. And again, both corneas clear. So Meesman's is associated with mutations in 2 different genes. We know the genetic basis of it and most of the corneal dystrophies. So we screened the exons in which mutations had been previously identified. And in the patient, we did not see a change in the KRT3 gene. We did not see a change in exon 1 of the KRT12 gene, but when we looked in the KRT12 exon 6, we actually found 3 heterozygous nucleotide substitutions that resulted in 2 amino acids changed. Neither of these has been reported in any of the SNP databases, so these are novel and unique to this patient. In fact, neither present in his parents. So in this case, this is a spontaneous form of Meesman's dystrophy, in which case the clinical picture was a bit muddied because of the atypical appearance and because of lack of a family history, in which case it was confirmed with genetic testing. Again, underscores the fact that these conditions, although they're dominant, may not necessarily have a positive family history. So you have to be very suspicious. I'm low on time. I was going to go through this case fairly quickly. There's a 47-year-old woman with a history of glare and photophobia since childhood, previously diagnosed by an optometrist with corneal haze in each eye. Again, there's no family history. We'll see this patient. If this is on a board examination, the answer would be Schneider corneal dystrophy. It looks pretty classic with the arcus and the corneal crystals. You can see there those crystals in the superficial cornea. And that was the right eye here, the left eye, less prominent, but still present, where the central corneal crystalline changes. In this case, we looked at other family members. In a sister, both corneas looked clear. A son, both corneas were clear. Father, he did have a bit of arcus, but it was thought to be just arcus senilis. There were certainly no central corneal changes. And the mother, both corneas clear. So we looked at the gene associated with Schneider's corneal dystrophy, UBI81. In the individual who's affected, we in fact did find a change in the DNA that was not present in a 200 control chromosomes, never been reported before, so a novel mutation associated with this condition. And we looked in both parents. Like the last case, again, neither has the mutation. So in this case, everybody else in the family was normal, other than the proband, the individuals affected who had the mutation. And you may be thinking, well, maybe that's not the father. Well, we did what's paternity and maternity testing and confirmed this, in fact, was the biologic father. So this is a case of a confirmed spontaneous mutation associated with inherited corneal disorder. So what are the indications for genetic testing and diagnosing corneal opacification? Absence of a family history, absence of typical associated symptoms like recurrent erosions or glare, atypical clinical features, as we saw in a couple of these cases, late onset of the stromal deposits, posterior stromal location of the opacities in regards to the TGF-beta eye dystrophies, and unilateral or markedly asymmetric involvement. Molecular genetic testing provides a rapid, inexpensive, non-invasive, definitive means of identifying individuals at risk of significant complications following ketorefractive surgery, differentiating between dystrophic and neoplastic corneal protein deposition, between dystrophic and degenerative corneal opacification, and diagnosing suspected dominantly inherited corneal dystrophies in the absence of a family history. I want to thank all the folks who did the genetic testing that I've shown you, and thank you very much for your attention.